an original.
From Story Studio Network.
Welcome to The Fatigue Fixer, the podcast where we get real about why you're so tired and what you can do about it. Every 2 weeks, we'll gather here for honest, heart-to-heart conversations about reclaiming your energy, your patience, and feeling truly at home in your body. I'm Dr. Sarah Vadeboncoeur, a naturopathic doctor, Menopause Society certified practitioner, Enneagram 3 entrepreneur with enough business ideas to last me 10 lifetimes, and a hockey and baseball mom. Over the past 15 years, I've helped thousands of women just like you cut through the confusion and finally feel like themselves again. And now, I want to hear from you too. Use the link in the show notes below to leave me a voicemail, to share your story, give feedback on an episode, ask a question, or tell me what's been exhausting you. And your voice might even make it onto the show. Together, we'll get to the root of what's really draining your energy and give you the tools, clarity, and encouragement you need to fix your fatigue. I hope you enjoy today's episode. I don't have a lot of regrets in my life. I've definitely made mistakes. I've changed my mind on things. But there aren't many moments that I look back on and think, I really wish I had done that differently. One of the few things I do regret, though, is how much I downplayed the importance of high cholesterol early in my career. Through my training and from some of my mentors, I somehow came to genuinely believe that cholesterol was being overemphasized. It wasn't that big of a deal. I remember talking a lot about inflammation, and I questioned statins. And I definitely talked some of my patients out of taking medications that, when I look back on it now, would have reduced their cardiovascular risk. And that's uncomfortable to say out loud, but it's true. And with a lot more experience and a commitment to lifelong learning, and also a willingness to change my mind, my thinking has changed. And I'm okay with that. I want my thinking to evolve when I'm presented with new information. And part of why the topic that we'll talk about today matters so much to me is personal. My best friend lost her dad to a heart attack. And once you see the impact of something like that up close, heart disease stops feeling abstract, like something that just happens to other people. So if I can use my voice, my knowledge, my experience, and hopefully the trust that you have in me to help reduce the chance of something like that happening to you or someone in your family, that feels like time well spent. And this is where things can start to get complicated because we've never had more access to health information. Like, we can Google anything in a split second. We can listen to podcasts. We can follow all these amazing doctors on social media. We can even ask an AI to act like our own personal doctor. And yet, so many people feel more confused than ever. And one of the most exhausting parts of modern health isn't actually doing all the things, it's figuring out who to trust. Because no matter what you believe about cholesterol or statins or diet or supplements, you will always be able to find someone out there with credentials and confidence and a platform who agrees with you. And so when you're sitting in the middle of all of that, trying to be proactive about your health, that constant sorting and second guessing is exhausting. And that's why I think cholesterol is such a useful place to start this conversation. So let's talk about cholesterol. Now, before you turn this off and think, my cholesterol is fine, I don't need to worry, I don't have a family history of heart disease, I want to urge you to keep listening. Because sadly, heart disease and stroke are still the #1 cause of premature death among women in North America. And now this is not going to be a fear-based conversation. It's not a statins for everyone conversation either. It is a context conversation. I want you to understand your risk, some of your risk factors in the context of your life. Because one of the reasons cholesterol causes so much confusion is that we're not even talking about it accurately, right? We always talk about good cholesterol and bad cholesterol as if they are two different substances. They are not. There is only one type of cholesterol. It is neither good nor bad. It's just cholesterol. When we talk about LDL and HDL, those are not actually types of cholesterol. Those are transport molecules. So when you go to the doctor and you get blood work and they look at your cholesterol, two of the big numbers they're looking at is your LDL, which is the one that we label bad, and your HDL, which is the one that we label good. Again, those are not two different types of cholesterol. They are transport molecules. So they are basically delivery systems that move cholesterol around your body to where it's needed. So LDL, the supposed bad stuff, takes cholesterol and carries it from the liver out to the tissues in the body where it can build plaque in the arteries, which is why that one increases your risk. HDL helps to transport cholesterol back to the liver for removal, which is why it's labeled as good, because it takes cholesterol out of the circulation. The problem is when we label one as good and we label one as bad, number one, that's inaccurate, but we are also oversimplifying something that was never meant to be simple, and that alone sets people up to misunderstand their risk. Because cholesterol often gets discussed in extremes, right? Either it's like, I must treat it at all costs and we must go on medications, or the flip side is like, you don't need to worry about it. It's not a big deal. I don't know why everyone's getting freaked out about cholesterol. And like with a lot of things, the truth sits somewhere in the middle. Cholesterol does matter, but it's also one risk factor among several others that determine your overall risk for heart disease. But cholesterol is a really important part of this puzzle because that LDL, right, that part that's taking the cholesterol into your arteries where it can make plaque, that LDL transporter plays a causal role in the formation of atherosclerosis, which is the fancy word for the formation of plaques. And that word causal is very important because it means that having high cholesterol isn't just related to heart disease, it is part of what is directly causing it. And if we can lower that LDL, whether that's with diet, supplements, or medication, especially in people who are at higher risk, we can reduce the risk of heart attack and strokes. That part of the science is very, very clear, and it's really solid. But where things start to go sideways is in how that information gets shared, right? Your cholesterol numbers don't sit in isolation. Again, they're part of your risk alongside things like your age, your family history, your blood pressure, your blood sugar, whether you smoke, your inflammation. But when that context is missing, people just look at that one number, that cholesterol number, and they either get scared or they dismiss it altogether because they think, well, I'm healthy, so I don't have any other risk factors. This doesn't really matter that much. And neither of those reactions is helpful. During the pandemic, I actually noticed my own cholesterol was creeping up. And I did what a lot of people do. I explained it away, right? I was like, ooh, it must be stress. Must be the cocktail I'm having at 4 p.m. every day because I survived another day. I was eating not as well as usual. We were living through a global crisis, right? All these like reasonable explanations. And for a while, that story felt good enough. But later, with more detailed testing, which I'll talk more about, I actually learned that I have a genetic risk factor that significantly increases my risk for having high cholesterol and for cardiovascular disease. And that really started to change the conversation in my own thinking around cholesterol. So suddenly it wasn't just like, ooh, I need to maybe eat a bit differently and up my fiber, or I need to manage my stress. It was really helping me to think about, I need to understand my baseline risk, and I really need to think about what this means long term. And this is why conversations about cholesterol are so important for women, because sometimes it is influenced by your lifestyle. Sometimes it's driven by genetics. And for a lot of us, it's both. One piece of the puzzle that really gets missed a lot when we talk about cholesterol is the role of time. So when we look at your risk, it's not just about how high your cholesterol is, it's about how long your arteries are exposed to it. I'm 43. My risk right now of having a heart attack or stroke, even though my cholesterol is high, is very, very low. It's 0.3%. And that is true for most women my age. Even if you have pretty high cholesterol, our risk is still low because we're young. So our body hasn't been exposed to that much cholesterol. And especially if you don't have any other risk factors, your risk is still relatively low. So that makes it sound like, well, that's super low. Why would I worry about it? But here's the thing. Even with slightly elevated LDL cholesterol, if that is present year after year, decade after decade, that can significantly increase your lifetime cardiovascular risk. So my lifetime risk is about 39%. I will share the calculator in the show notes that I'm using to come up with these stats. This is a calculation I do for my patients when we get cholesterol results because I think it's a very important part of the conversation. It's also, some of these numbers are what help us figure out who is a good candidate for statin medication and who is fine to treat this through diet and lifestyle. Now, we need to keep in mind that calculators are not perfect and they can often overestimate the risk. But I hope that my example helps to show you that even though right now, as a 43-year-old healthy person, my risk right now is extremely low. But again, when I am 75 or 85, if I do nothing, and even if my cholesterol magically stays the same, which it usually goes up as we get older, even if it magically stayed the same, my lifetime risk would be very high, right? 39%. Atherosclerosis or plaques do not happen overnight. They are a very slow, cumulative process. And the earlier that exposure starts, the more it adds up over time. So when we dismiss younger women with high cholesterol, when they get brushed off being, oh, you're still young, that can create a false sense of safety. And it's not because the concern is urgent. We're not worried about you today, but we do want you to be aware that long-term you are at higher risk. And again, that doesn't mean that everyone needs medication in their 40s. It doesn't mean that we need to be radical. Doesn't mean you're doomed to have a heart attack or stroke, but you need to be aware. I would love for you to be aware. I'm happy that I am aware because what that allows me and you to do is to take action on the factors that are within your control, right? So things I'm working on is like, I'm really mindful of my fiber intake. I am reducing my intake of saturated fats and I'm managing my stress, right? I can't change my genetics. I can't change who my parents are. I can change the things I do every day that impact my cholesterol. A lot of times this idea that we're going to watch and wait, watching something shouldn't mean doing nothing and seeing what happens. It means we should be taking proactive steps and seeing what the trend is with your cholesterol over time. I want to address some of the things that I hear all the time in my office that really have prompted this whole episode and this conversation. Because whether it's things I hear in my office, whether I'm scrolling Instagram, these are things that I hear and see all the time. And they are myths and misunderstandings that cause a lot of unnecessary worry, but they also often will guide women down the wrong path. They will sometimes make women feel like, I don't need to worry about cholesterol. It's not a big deal. I saw online that I don't need to worry about it. And some women who actually are very high risk refuse to take medications like statins because some of these misunderstandings that they're seeing. The first one that comes up a lot is this idea that my brain needs cholesterol, so lowering cholesterol is dangerous, right? If I take something that lowers my cholesterol, it's going to be bad for my brain. This one comes up all the time. And there is some truth to this. Your brain absolutely needs cholesterol. But here's what most people on the interweb are not telling you. Your brain makes its own cholesterol. Brain cholesterol is completely independent from the cholesterol that is circulating in your blood because we have something called a blood-brain barrier. That is this barrier designed to keep things out from entering your brain because we want to be very selective about what is allowed to enter the circulation of the bloodstream. So the cholesterol that's flowing in your bloodstream is not going up to your brain. Your brain is entirely responsible for making its own cholesterol. So whatever your brain needs, it will make it. So if you take a medication that lowers the amount of LDL or cholesterol in your bloodstream, you are not depriving your brain of cholesterol. So if this is what you are worried about, if this is the argument that you've seen, it is an oversimplification and it is a misunderstanding and one that causes a lot of unnecessary fear. Another one that's kind of along the same vein is I need cholesterol to make hormones, right? If I lower my cholesterol, it's going to be bad for my hormones. So yes, again, there is some truth to this. Cholesterol is a building block for making steroid hormones. So your estrogen, your testosterone, your progesterone. But we are not using circulating LDL cholesterol to do that job. Again, your body can make all the cholesterol it needs for hormones. Most of the cholesterol that is in your body is made by your body, and your body can make however much cholesterol it needs in order to make those hormones, right? Most of the cholesterol that's floating through your bloodstream is not being shuttled directly into making hormones. If we do something to lower your LDL cholesterol, that does not mean that you're not going to have anything left to make hormones. Number 3, if my HDL, again, in air quotes, good cholesterol is high or normal, then I don't need to worry about my high LDL. I hear this from patients all the time, and they're being told this by their doctors. This is still a very prevalent misunderstanding. I really wish this one would disappear. So again, HDL and LDL are not two different types of cholesterol. They're different transport molecules. They're just taking cholesterol to different places. They are not like opposing teams where one of them wins or cancels out the other. So having higher HDL does not undo or erase the risk associated with having high LDL, especially over time, and especially if you have other risk factors. So HDL can be a marker of certain healthy behaviors. So 2 of the big things that influence HDL are exercise and your intake of healthy unsaturated fats. So think olive oil, nuts and seeds, avocados. So you can have a normal HDL, maybe because you have those behaviors or just because genetically you're gifted in the HDL department. That does not undo or protect you if you also have high LDL. So a lot of times people underestimate or kind of dismiss their high cholesterol because they're told, well, your HDL is normal. Now, certainly if your HDL is low, that increases your risk for sure. But having a normal amount of HDL does not cancel out high LDL. If your LDL is high, you are at higher risk no matter what your HDL is doing. Okay, this next one I think came out of the whole carnivore craze, which I pray to God is on its last leg, but it still is around, so I want to address it. And it's this idea that saturated fat is not what raises your cholesterol. You can eat all the bacon and meat and drink your butter and gargle with it, and it's fine. That is complete bullcrap. For almost everybody, saturated fat does raise LDL cholesterol. Now, where there is some nuance to this conversation is that different types of saturated fats can have different impacts. When we look at saturated fats that come from animals, so that come from especially meat, they can significantly raise your LDL. Now, different people are going to have a different effect. Some people might be very sensitive to the saturated fat they eat, and other people can afford to eat more and be fine. So there is some variability, but this idea that it doesn't raise cholesterol is untrue. If we look again at the different types of saturated fat, for example, if we look at dairy, butter raises cholesterol a whole lot more than other types of dairy. If we look at something like coconut oil, which is a saturated fat but a plant-based, it doesn't raise it as much as butter, but it raises it more than olive oil because olive oil is not a saturated fat. So if you see someone online peddling a super high meat, buttery, high saturated fat diet, and they tell you with confidence that it doesn't affect cholesterol, they either don't know what they're talking about, or what they might mean is like, well, it didn't cause any problems for me, therefore it must be fine for everybody else. And again, for the vast majority of us, that's not true. eating more saturated fat does raise our cholesterol. Okay, we can't talk about cholesterol without talking about eggs. But the issue with eggs is that eggs contain cholesterol, right? So logically, it makes sense that if you eat more cholesterol, your cholesterol level is going to go up. However, dietary cholesterol only makes up a fraction of our blood levels of cholesterol. Again, the vast majority of our cholesterol in our body is made by the body, and it's often made in response to saturated fat, not actually eating too much cholesterol. So dietary cholesterol is not the primary driver of high cholesterol for most people, but not the main driver is not the same as never relevant. I'll go back to my example. When we look at my cholesterol, my LDL is too high, but my HDL is also quite high. And what that means is that some people appear to be what we call hyperabsorbers of cholesterol. I am probably in this category where my body loves to absorb some cholesterol. So when we see that, when your HDL and your LDL are high, that may be a sign that you're just really good at absorbing cholesterol. And in that kind of case, then yes, eating too much cholesterol may also meaningfully raise your LDL. But for the vast majority of people, your cholesterol is not high because you're eating too many eggs. And then last but not least, I feel like I've touched on this in prior episodes, but I feel like I need to keep reiterating it because it won't die, is the seed oils. So this idea that it's not fat, it is seed oils that are causing heart disease and high cholesterol. This has become very loud. People say it very confidently. And so I want to be clear about it. Seed oils are a distraction. We actually have a large body of research looking at what happens when we replace saturated fat with polyunsaturated fat, which is what seed oils are, some of them. And what those studies show is this. When we take saturated fat, aka your butter and your bacon and your fatty steak, and we replace some of that with seed oils, it either has no effect or a beneficial effect on cholesterol. It does not have a negative effect. It either is neutral or beneficial. We see that LDL cholesterol tends to go down. And the other big claim that it increases inflammation also has not been shown to be true. If anything, again, inflammatory markers tend to improve or they stay the same. And people say, well, what about the highly processed ones? The studies are using the highly processed seed oils, the very ones that everyone is worried about, and we do not see an increase in cardiovascular risk. So in other words, seed oils are not what is driving our heart disease epidemic. Now, does that mean that they're a health food? No. The problem with seed oils is they are often contained in ultra-processed foods. So usually people who have a diet high in seed oils have a diet that is high in ultra-processed foods. So of course, they're not going to have great health outcomes. But it's not the seed oils themselves that cause the issue. It is the intake of the ultra-processed foods. We need to stop blaming the seed oils. Again, they're definitely not a health food. I'm not telling you to go mainline canola oil, but we need to not pretend that or blame the seed oils for high cholesterol and cardiovascular disease. That is not supported by the evidence. And again, I think it is a distraction. It's like an easy distraction. It's an easy boogeyman to blame, which distracts us from the things that we are very clear on, which is the main driver for the vast majority of people is saturated fat, not seed oils. Are you tired of being told everything is normal, even though you're exhausted and don't feel like yourself? You deserve better care than that. In my one-on-one practice, I help women just like you do a deep dive to figure out what's really draining your energy. Together, we'll get answers and create a clear, personalized plan to help you start feeling like yourself again. If you live in Ontario or the Outaouais region and you're ready for the next step, visit drsarahv.ca to learn more and book your appointment today. Because being tired all the time isn't normal, and you don't have to keep pushing through it. Okay, those are all the myths. I got them all off my chest. Some of you are going to hate them, and that's okay. My goal here is not to be liked. It's to hopefully give you a different perspective to contemplate. Another thing I think that women don't fully appreciate is that there are very specific risk factors that we can have that we don't do a great job letting women know that these are specific risk factors. There's kind of two times we'll talk about. The first one is pregnancy. And pregnancy is essentially your first cardiovascular stress test because your blood volume goes up, your heart is working harder, your blood sugar regulation changes, and your whole vascular system is under real strain. And how your body responds during pregnancy gives us information about your long-term cardiovascular risk. But a lot of times, once the baby is born, we kind of forget all about that, right? A lot of things come back to normal and we assume, well, that was just pregnancy and now I'm not pregnant and everything is fine. But I want you to be aware of these risk factors. So the first one is hypertensive disorders of pregnancy. So that includes gestational hypertension. So that is high blood pressure that develops after 20 weeks. And preeclampsia, which is high blood pressure with protein in the urine. So if you had either of those in any of your pregnancies, even if your blood pressure came back to normal after you delivered and has been normal ever since, these conditions are associated with a higher lifetime risk of high blood pressure, heart disease, and stroke. So again, this is not to scare you, but this is for you to be very knowledgeable that if you had high blood pressure in your pregnancy, you are at higher risk for high blood pressure for the rest of your life. And sadly, like cholesterol, high blood pressure often doesn't cause any symptoms until it's like extremely high. So you need to keep an eye on your blood pressure if you have had issues with your blood pressure at any point, especially in your pregnancy. The second one is gestational diabetes, which is diabetes again during pregnancy. It's not just about your blood sugar. It's again another sign that your body is struggling to manage glucose under stress. And women who have had gestational diabetes, again, you're at higher risk for diabetes for the rest of your life. You're at higher risk for insulin resistance, which is a precursor to diabetes. And you're at higher risk for cardiovascular disease later in life. Again, even if your blood sugar is completely normalized after you had the baby, you need to be watched more closely for blood sugar throughout your life. The next one is preterm delivery. If you delivered a baby before 37 weeks, that can also be associated with an increased cardiovascular risk. And this one surprises a lot of people because it doesn't feel like a heart issue. But preterm delivery often reflects an underlying like vascular or inflammatory stress that shows up years before we would see any of the more classic or traditional heart disease symptoms. And then the size of your baby also matters. If you had a very small baby, especially for their age, so if they were under the 10th percentile of birth weight for their age, that like the number of weeks that they were born at, that can also be a sign that there might have been issues with the placenta and vascular challenges during your pregnancy, and that those same vascular patterns are linked to higher cardiovascular risk down the road. On the flip side, if you had a really big baby, over 8 pounds, 13 ounces, that can also be a marker because that can often be a sign of underlying insulin resistance or glucose dysregulation during pregnancy, even if you didn't meet the criteria for gestational diabetes. And a lot of women are never told. I know I was not told any of this when I was pregnant. I mean, knock on wood, I was lucky I didn't have any of these. Although my son was quite big. I need to go back and check how big he was. I don't think he was 8 pounds, 13 ounces, but he was definitely well over 8 pounds. So I need to go back and see. The point of this is these are all risk factors that often are showing up earlier in life that, again, we don't always fully let women know that those are things that need to be checked on regularly and that those are often like very early signs that they might be at underlying risk. Where a lot of this comes back or shows up for the first time is in perimenopause and menopause. So this is another time where cardiovascular risk becomes more visible. And for a lot of women, this can feel really unsettling because a lot of times they're like, I haven't changed anything. Like, why is my cholesterol going up? As women go through perimenopause and menopause, estrogen is fluctuating and then eventually declines. We tend to see your LDL cholesterol rise. And that protective effect that estrogen was having on the blood vessels starts to lessen. So again, for many women, this is the first time their cholesterol is flagged, again, even though their diet or lifestyle hasn't changed. And that often leads to a lot of questions. And I think this is one of the loudest, most polarizing areas in women's health right now. Because again, if you go online, you will hear very confident voices saying completely opposing things about hormone therapy, right? You have one camp, which is like, put it in the water. It's good for everyone. It's good for everything. It will protect you from heart disease. And then you have others saying we shouldn't use it to prevent heart disease. If you're a woman online just trying to understand, what is happening to my body, and I'm just trying to be informed, that back and forth is incredibly frustrating. And again, it's frustrating because a lot of these voices are very well educated. They are very smart. They're very confident in what they're delivering. And so it can be really hard to know who to trust. And again, this is where context matters. This is where nuance matters. So when we look at the role of hormones and heart disease, women who start hormone therapy within 10 years of their final period or before the age of 60, there is evidence that it can reduce the progression of atherosclerosis, there's that plaque again, and lower the risk of cardiovascular disease and even all-cause mortality. So if women start taking hormones earlier, it does seem to have some benefits for heart health, right? Timing matters because on the other hand, if women start hormones more than 10 years after their menstrual period or after the age of 60, we see increased risk, right? Increased risk of cardiovascular disease, more thromboembolism, which is a fancy word for clots, and stroke. So obviously in those situations, we would not recommend putting a woman HR on HRT for the primary prevention of heart disease. And I think it's really important to reiterate this. Even though we have some evidence that especially if we started early, it does seem to have a proactive and preventative effect, currently there are no Menopause Society guidelines which recommend HRT for the prevention of heart disease. We still don't have enough data to say, yes, women should take this to help prevent heart disease. Most things in health require nuance, right? What I just said, if I created a reel on Instagram saying that, it would not perform very well. If I go on and I say, hormones help reduce heart attack and stroke. It's safe for everyone. Everyone should take it. That is going to perform a whole lot better than well, it depends, right? This is why so much of the messaging online is getting oversimplified because they're just trying to get a message out that people will understand. But this complex, nuanced data, it gets flattened into HRT is good or HRT is bad, neither of which is very helpful. And then women feel confused. They feel like they're missing something. They don't know what decision to make. They don't know who to trust. And that is a huge issue. So the reality is that perimenopause and menopause, they are not suddenly creating cardiovascular risk out of nowhere. What's happening at perimenopause, and again, same thing as pregnancy, because these are hormonal stress tests, they're often unmasking risk that was already there. And this is why, especially in midlife, sometimes we need more than just our standard cholesterol panel to really understand what's driving the risk. So another big shift for me in my own thinking happened during a whole course that I did on cholesterol. And part of that was talking about genetics and family history. And I was sitting there listening to that lecture, and some of the risks started to feel very familiar. So some of the things I learned is that people with a French-Canadian heritage have a higher prevalence of inherited cholesterol disorders. I am French-Canadian. The course also revealed that physical signs can appear years before an event. And two of those signs I immediately recognized in my own family. So one is something called xanthelasma. These are soft, yellowish, fatty deposits that often appear as plaques like on or around the eyelids, near the inner corners, and they're basically collections of cholesterol under the skin. My grandpa had those. The second one is something called a corneal arcus. It's a gray or white ring around the cornea. Again, my grandpa and my dad both have that. As soon as I heard that, I was like, oh, something is clicking. Maybe this explains why my cholesterol is so high. And so once those genetic clues were on my radar, I definitely wanted more information. And I want to share two tests that I did that have made a big difference. And these are tests that I advocate for my patients to do as well. The first one is called ApoB. ApoB reflects how many cholesterol particles are circulating. So again, when you get a regular cholesterol test, it's telling you how much cholesterol, right? So how much LDL do you have? ApoB is measuring of that LDL that you have, is it made up of like a whole bunch of small particles, or is it made up of a few big particles? If your ApoB is high, it usually means that you have more small, dense particles that are more likely to contribute to plaque. If your ApoB is high, that increases your risk. Again, even if your LDL is not that high, if your ApoB is also high, that increases your risk. If you have normal ApoB, your risk is not as high. Again, it doesn't undo your LDL result, but it's like an added piece of information to the puzzle. And then the one that was a really game changer for me was lipoprotein A, or Lp(a). This is a genetic risk marker. It is not affected by lifestyle. And when I tested mine was nearly double what it should be. Now I had a better understanding of what's driving up my cholesterol. So this is a test that I highly recommend for anyone over the age of 40. The Canadian Cardiovascular Society recommends measuring it once in your lifetime. So it is a genetic test. You don't need to do it multiple times. And the goal, even if yours is high, the goal is not to try to bring it down. The goal is to bring your cholesterol down. It's recommended to be done once in your lifetime, especially for people who have a family history or who have really high LDL cholesterol. If you want to understand a little bit more about ApoB and Lp(a), like who should test, what to ask for, what ranges we're looking for, I walk through all of that in my free lab guide, The Missing Piece, which I will link to in the show notes. I want to come back to where we started. One of the reasons I really wanted to have this conversation is because my own understanding of cholesterol has changed a lot over time. Not just because it affects me personally, but it's because it's a conversation that I now have every single day in my office with women of all ages and all different health histories. And I feel so much better equipped now to have those conversations calmly and honestly, because I'm more familiar with the evidence and the outcomes and the complexity that, again, doesn't translate well online. And that's really something I hope you take away from today. These are nuanced conversations. The internet is not a great place for nuance. So when we're looking at topics like cholesterol and hormones and whether or not I should take HRT and whether or not I should worry about my cholesterol, if we are just using quick sound bites to make our decisions, we're often going to miss out. We're often going to be misinformed. We're going to often be more confused. And again, there's this huge issue of like, who do I trust? And that's why I think having a strong, trusting relationship with your healthcare team matters so much. And they've studied this, right? A big part of the benefit of going to the doctor is the relationship you have with the doctor. And I know that can be really difficult if it feels rushed or you feel like you're not being listened to. But really working to cultivate that strong, trusting relationship with someone on your healthcare team is really important, because you want someone who can walk you through this conversation and personalize it for you based on your cholesterol, based on your family history, based on your genetic risk factors, help you understand your risk today and what that risk looks like 30 years from now, and then help guide you and help you think through the decisions that need to be made over time. I also want to say this clearly because a lot of times it's hard to do online to say, oopsies, I was wrong. I changed my mind. Some of the people I respect the most online are actually the people who are capable of doing that. And I want to say that it's not just okay to change your mind. It's a sign that you're paying attention. So maybe like me in the past, you were like, cholesterol's not a big deal. I can eat all the butter I want. That's a lie. I'm hoping that you're open to hearing a different approach and that maybe something you heard today may help you to start changing your mind. Updating our thinking and changing our mind as the evidence evolves is not failure. It's a sign that you're open. It's a sign that you are willing to learn something new. And that's actually how good healthcare happens, right? If we just practice the same thing we learned in school, we'd be practicing very outdated medicine. If this episode helped you feel a little bit more grounded, a little bit more informed about cholesterol, and a little bit more confident asking better questions of your healthcare team, that is exactly what I was hoping for. Because again, heart health is something that impacts us all. Some of us will be impacted more than others, but there is so much that we can do that is within our control. There is so much information that can help you better understand your risk. So I would encourage you to stay informed and stay curious, and also just stay connected to the people who are helping to guide your care. Thank you for listening. We'll see you back here soon. I know your time is precious, so it means so much to me that you're here. If you enjoyed this episode, share it with a woman in your life who could use a little extra energy and encouragement today. It's a small way to show her you care, because we're all in this together. Wondering what the next step is? Find out what's really draining your energy by taking my fatigue fingerprint quiz at fatiguefixer.ca/quiz. You'll discover which of the 5 most common types of fatigue you're dealing with, like frazzled fatigue, where your body's exhausted but your mind won't turn off, or drained fatigue, where no amount of sleep ever feels like enough. Your results will include recommended labs to ask your doctor about, plus my top suggestions for habits and practices that can help you start feeling more rested, calm, and in control. Because here's the thing, being tired all the time isn't normal, and you deserve to feel like yourself again. And hey, if you've got a story to share, a question, or just something on your mind, leave me a voicemail. Your voice might even make it into a future episode. Thanks again for listening, and remember, it's not all in your head. I believe you, and we'll figure this out together. I'll see you right back here in 2 weeks.
This is SSN.
Story Studio Network.